I'm the director of the Bing Center for Waldenstrom's macroglobulinemia at the Dana-Farber Cancer Institute, and I'm a professor of medicine at Harvard Medical School. I want to thank the organizers for giving me the opportunity to give this update in the management of Waldenstrom's macroglobulinemia. And a special thanks to Dr. Remu for organizing this brilliant meeting in Indianapolis, although virtual, for this patient presentation. I certainly look forward to next year, this being live. These are my disclosures that include disclosures for research support that I've received along with consulting fees. In addition, during this presentation, I'll be talking about a number of drugs which are investigational, meaning that they're not FDA approved for the specific use in Waldenstrom's, and this includes at this time zanubrutinib, acalabrutinib, ulocuplimab, movorexafor, and venetoclax. Although these drugs some of these drugs could be approved for other indications. These are my objectives today. I want to talk about the different genomic subtypes in Waldenstrom's, how we can actually use that information for treatment strategies, and to talk a little bit about some of the clinical trials, their outcomes, toxicities, and the benefit derived. So I think what is important from the get-go is to know that there are two very important mutations in Waldenstrom's. About 95% of the patients have a mutation in the MYD88 gene, and another 30 to 40% have a mutation in CXCR4. Now, why is this important? Well, MYD88 is a driver of a particular immune response pathway, which is called the toll receptor pathway. These are antennas or receptors that sit on the cell surface. They signal when they come across bacteria or viruses. And normally what they're supposed to do is excite MYD88 to turn on this very complicated survival pathway that allows the cells to grow and multiply and respond to the infection. But if you have a mutation in MYD88, this means that this cascade is turned on without the benefit of a virus or bacterium actually triggering this. So as a result, the cell just keeps thinking that there's an infection, and this kind of signaling pathway is turned on. And part of the signaling pathway, which is why I wanted to show you this diagram, includes Bruton's tyrosine kinase, which is the target of a lot of interesting BTK inhibitors, including drugs like ibrutinib, zanubrutinib, acalabrutinib, tirabrutinib. We'll be also talking a little bit about LOXO 305, which also is known by the name pirtobrutinib. But all these go after BTK. Now, MYD88 can also do another thing. It can actually turn on this other molecule called HCK. And this is what turns on BTK and some other survival pathways that also allow the Waldenstrom cell to grow and survive. And drugs like ibrutinib and zanubrutinib can also have an effect on HCK, but also some new drugs that are being developed, including KIN 8194. Now, I want to switch a little bit and talk about CXCR4. This is a fascinating target. This is actually, when it's mutated, it causes Waldenstrom cells to want to go to the bone marrow. And here too, we have the opportunity for therapy interventions, including drugs like ulocuplimab and movorexafor that actually block CXCR4. So I'm hoping to actually talk to you today about both MYD88 and CXCR4 inhibitors. So I already mentioned to you that ibrutinib blocks BTK and HCK, and therefore of great interest. And this is what propelled us to do the first ever trial of a BTK inhibitor in Waldenstrom's macroglobulinemia. We just updated this data in the Journal of Clinical Oncology. And in fact, these were all patients that were heavily pretreated. They had on average 2 prior therapies. 40% of the patients did not respond, or what we call refractory to their previous therapy. And despite that, 90% of the patients had a response, at least a 25% reduction in their IgM. Almost 80% had a major response, meaning 50% reduction in their IgM. And there's even this category of very good partial response, meaning at least 90% reduction in their IgM. And this occurred in 30% of patients. But if you look here to the right, you see the different genomic profiles. You've got people that have only the MYD88 mutation, and 97% had a major response. Almost half had a very good partial response. But if they have the 2 mutations together, you see that the depth of response here particularly getting to those VGPRs, which much less. And if they had no MYD88 mutation at all, then these patients didn't have a major response. So you see how the genomic subtypes make a difference. Also important to point out that if you had both mutations, the MYD88 and the CXCR4, it took much longer to get to a major response than it did if you only carried the MYD88 mutation alone. So this is important to keep in mind, that this can also affect the time to getting to one of these major responses. Now, some good news here. At 5 years, 54% of the patients still remained without their disease progressing. 87% were alive at 5 years. And if you keep in mind that these were, again, heavily pretreated patients, 40% were refractory to their previous therapy, meaning they didn't respond. These are numbers to get excited about. And you can see that the genomic profiling also played a role in how long somebody was in a remission, free of their disease progressing. And it was much better for those patients that had only the MYD88 mutation. It was about 42 months if they had the two mutations. And if they didn't have a MYD88 mutation, you see, in fact, that these patients progressed much sooner. And down here on the x-axis, you're seeing the number of years that actually elapsed. Now, the side effect profiling was also updated by us in this Journal of Clinical Oncology report, now with almost 60 months of follow-up. And I think the one thing that just maybe keep in mind is that there were more events of atrial fibrillation. This is an arrhythmia of the heart, with 13% of the patients having an atrial fibrillation by this updated reporting. But almost all these patients still stayed on ibrutinib with medical management. So that's what's important to keep in mind. You will hear about BTK inhibitors having associated atrial fibrillation, but in the most of these patients can still be kept on therapy with medical management. Now, there was a trial called the INNOVATE trial I want to talk about that followed our initial pivotal trial. The initial pivotal trial actually led to FDA approval of the drug, but then came along the INNOVATE study. And this was a randomized study. It was multinational. And here patients either got ibrutinib and Rituxan together, or they got a placebo and Rituxan. It was really meant to test what the benefit of ibrutinib was over rituximab alone, which is an important community standard. And if the patients progressed on the placebo and Rituxan, they were allowed to cross over and get ibrutinib. That's important because sometimes when this happens, it affects what we call our survival analysis. So the take-homes here that are important is, regardless of the genomic subtype, those patients who got ibrutinib did better than those patients who got rituximab. It's a bit of a surprise to see the very high response rate in the MYD88 wild-type patients, which means patients that had no MYD88 mutation. And I want to talk a little bit about why that surprise may have come about. Now, what you also need to keep in mind is whether the patients were previously untreated or previously treated. Again, they did better if they got ibrutinib and Rituxan as opposed to getting Rituxan alone. And in fact, one of the very pleasant surprise here was that the patients that got ibrutinib and Rituxan had a quicker time to a major response with the CXCR4 subtype as well. Now, what did we learn with longer-term follow-up? Well, what we learned is that the patients that had the CXCR4 mutation or any of the other mutation subtypes did better than Rituxan alone, but the ones with CXCR4 did show earlier progression than the other genomic subtypes. Now, one thing I want you to keep in mind here is that these patients here are those that have no MYD88 mutation. They're called wild type. And what you see here is this very quick drop off in terms of progression-free survival, much like we saw in the pivotal study. And I think this has to do, and you're going to see this with other trials too, is the way we test for MYD88 and CXCR4. It can be very different in these trials. When we did the pivotal trial, we actually isolated out the B cells, the Waldenstrom cells. Were in this selection. And then they were tested by a very sensitive technology called PCR, which can actually pick up down to 0.5% of all the cells. It can pick up that minuscule Waldenstrom population. But in these larger trials, it's not practical to do that because they're multinational, as I mentioned. So next generation sequencing, NGS, is often used. And here you can't really select out the cells, you subject them to NGS, and its threshold for picking up mutations is about 5% of the marrow. Some of them a little bit better than that, but on average it's about 5%. So if you compare these different technologies, as we did in these two publications shown below here, you miss 1 in 3 patients who truly have MYD88 if you're using NGS. You miss actually as much as 2 out of 3 patients if you're looking for CXCR4 mutations if you're using NGS over using tumor selection and more sensitive technology. So, and this tends to occur mostly in patients that have lower bone marrow volume of disease. So it's important to keep this in mind, because as we look at these different trials, this becomes an important lesson. Now, what did we also learn in the INNOVATE trial? What we learned was that the side effect profiles that were seen remained relatively stable with a long-term follow-up. There were more atrial fibrillation events with this updated reporting. However, 75% of the patients who developed atrial fibrillation remained on the therapy and could continue on without requiring discontinuation. So medical management accounted for their being ongoing on ibrutinib. Now, you probably have also heard about this other new drug, which is zanubrutinib. It's a very interesting new BTK inhibitor. And zanubrutinib was compared to ibrutinib in a trial called ASPEN. Now, here zanubrutinib was given twice daily, as opposed to ibrutinib given once daily. The follow-up was relatively short for this report. It was only about 19 months, so you have to keep that in mind. And here, there were 2 arms. One was for the patients that had only the MYD88 mutation. The other was for the patients that were wild type, having no MYD88 mutation. Among the MYD88 mutated patients, they were randomized to either get zanubrutinib or ibrutinib. And the patients that had the wild type all got zanubrutinib alone. Now, there were some very exciting lessons out of this, which I want to share with you. First is that when you looked at these head-on responses, again with a relatively short follow-up of 19 months, the major response rate was identical across the board. Numerically, there were more VGPRs in the zanubrutinib arm, although this did not reach statistical significance at this juncture in time. What was seen also was among the CXCR4 mutated patients that the number of patients getting into a VGPR were fewer than if the patients had no CXCR4 mutation. And this was regardless of what genomic subtype, although zanubrutinib patients had more VGPRs numerically than those that were on ibrutinib. And so I think it is important as a takeaway here that CXCR4 plays an important role even in zanubrutinib, as we saw also with ibrutinib. Now, the big story for this trial was the side effect profile. This was considerably different. There were much fewer atrial fibrillation events associated with zanubrutinib, less diarrhea, less bleeding, but there was more neutropenia. This is when the white blood cell count goes down. There were no more infections, however, associated with this decrease, but there was an increase in the use of G-CSF, which is the growth hormone required to be able to goose up that lower white blood cell count. So there are really differences here which are important to keep in mind, when one compares, these 2 different BTK inhibitors. And here's where, thoughtful consideration with clinicians is important to keep in mind. And there was also another trial just reported at the European Hematology Association meeting called the Alpine trial. This was in CLL patients. And I think here too, the lesser events of atrial fibrillation associated with zanubrutinib were also recognized, in comparison to ibrutinib. However, the more severe ones you can see here, the grade 3 ones, were accounted for about 1% and 1.9%. Now, I also want to share with you this other very important study just presented at the European Hematology Association, and that had to do with a trial which gave zanubrutinib to patients who were not able to tolerate ibrutinib or acalabrutinib, meaning that they were on ibrutinib, but they developed some side effect that required them to come off, in which case they could be swapped out for getting zanubrutinib, and they could receive it either 160 milligrams twice a day or 320 milligrams once daily. And this was also a very exciting trial in my mind because it included Waldenstrom patients, as you can see here, although the vast majority of these patients were CLL patients. Cohort 1 was for those patients that had ibrutinib before. Cohort 2 was for acalabrutinib. Now, what did we learn from this trial? What we learned was that, in fact, the recurrence of these ibrutinib intolerance events, which is what I'm going to focus on here in this slide, were actually didn't occur with zanubrutinib in 75% of cases. And you can see the different types of intolerances shown here that necessitated the switch over to zanubrutinib. So I do think this is an exciting trial to keep in mind that, you know, even if you're on ibrutinib and you develop side effects, that there is this ability to now switch over to another BTK inhibitor so that you can continue on this particular form of therapy. And there is also data with acalabrutinib, which was presented last year at the International Conference on Malignant Lymphoma, that had shown a similar switchover with acalabrutinib, although the amount of data that we had around atrial fibrillation was very, very small in that study, whereas here, actually, we do see a number of patients who had atrial fibrillation who were switched over. And here, you know, if you can see the count here, 9 out of 10 patients that atrial fibrillation did not recur. So again, the opportunity to switch over to zanubrutinib exists. Now, we learned one more thing about zanubrutinib, and that was that it was also active in the patients that had no MEDD8 mutation. This was in this trial reported in Blood Advances by my colleague Dimopoulos. And here, the major response rate was 50%, although keep in mind, some of these patients had no bone marrow disease burden. So it's quite possible that MEDD8 mutated patients were included in this cohort, but some of them actually, you can see, had a lot of disease burden, whether they were treatment naive or relapsed or refractory patients. And in which case, I think the readout of their correct MEDD8 status would have been there. But I think it does provide at least one other opportunity to use a BTK inhibitor in the treatment of patients who genuinely don't have a MEDD8 mutation. I also want to talk about this very exciting trial. This is a trial of venetoclax in previously treated patients. This is being run by my colleague, Jorge Castillo. It's a very exciting trial because we've seen a response rate of 84% overall, and major response rate, meaning at least a 50% reduction in the IgM that reflects really the underlying tumor burden in most patients, was 81%. And the median time before progression was 30 months. And most of these patients actually had seen previously, or many of them had seen previously, a BTK inhibitor. And you can see, you know, up here that in fact, you know, the reduction in their IgM was very similar whether they had no prior BTK inhibitor or they had a prior BTK inhibitor like ibrutinib. Also, the CXCR4 constraints were largely overcome. So you can see similar levels of reduction in IgM regardless of whether they were CXCR4 mutated or not. So this is an exciting new drug, I think, for Waldenstrom's macroglobulinemia. We also have evidence that when you combine venetoclax along with ibrutinib, at least in these laboratory studies here, that you can actually induce more tumor cell killing, whether you're looking at, you know, tumor cells that have been grown out in culture called cell lines that express either an unmutated or mutated form of CXCR4. So we are excited enough by all this data to actually currently be running this combination study of ibrutinib and venetoclax in patients that have previously not been treated, treatment naive, where they'll get a total of 2 years of therapy with the two agents, starting off with ibrutinib alone and then combining it with venetoclax for the remainder duration. And then all therapy will stop and the patients will be observed. And this is being run by my colleague, Dr. Castillo at our institution at Dana-Farber. Now, I just want to report on this trial. We just had this trial published, so this is really breaking news, where the CXCR4 antagonist antibody ulacuplamab was combined with ibrutinib in CXCR4 mutated patients with Waldenstrom's that required therapy. The patients were treated for a total of 6 months with the ulacuplamab antibody. And during the first 4 weeks, they got weekly ulocupilumab, and then it was twice monthly or biweekly. And what we learned in this trial is very exciting. Again, this just came online, published in the journal Blood. But when you look at these were largely patients that were treatment naive. The average time to get to a major response is somewhere around 7 months. But 2 months in, 8 out of 12 patients were in a major response. When you look at 4 months in, all of them were. And in fact, some of these people also got VGPRs. Here's the amount of IgM compared to their baseline. And you see people here tracking in VGPR territory very early on. So this is why I'm excited that we can actually do something about CXCR4. And this is also the case now with the drug Movarexafor, which is an oral inhibitor of CXCR4. So it gives us the opportunity to combine, 2 oral inhibitors, ibrutinib and Movarexafor, to treat patients with Waldenstrom's macroglobulinemia. This is an ongoing phase 1 study. I just presented this at the European Hematology Association, and it's too early really to gauge the efficacy in this trial, but we did see the IgM reductions and improvements in hemoglobin associated with the use of Movarexafor along with ibrutinib. But what was exciting was that the therapy was well tolerated, and the dose escalations for this trial continue. So there's going to be much more news on this later this year when we hope to present this at the American Society of Hematology. I want to talk a little bit about resistance. This is occurring now in patients who are receiving ibrutinib. We will be seeing this with the other BTK inhibitors, no doubt. And what we can do about this is really the subject of my remaining slides. Typically, it's patients that have the CXCR4 mutation that tend to be at higher risk for acquiring mutations in BTK. So this is at the site called position 481. This is where ibrutinib binds to BTK and inactivates it. But some patients can actually have multiple BTK mutations who start progressing on ibrutinib. And in fact, it's quite odd to see this kind of selective pressure on the cancer cells so much that multiple mutations then occur to allow an escape. So it does show you the target is genuinely a good target going after BTK. So there is a new drug called LOXO 305, or pirtobrutinib, as it's now been named. This is a BTK inhibitor that binds to a different site than that position 481 on BTK. And so we've been testing this in the laboratory, and we actually created mutants which actually express the BTK CYS481 mutation. And you can see what happens here. And these blue lines are really meant to show what happens in the cells that have the mutation introduced into them. And what happens is resistance is created, whether you use these MYD88, mutated cell lines that we do in our experiments. But if you add in then pirtobrutinib, you can see the lines really collapse on each other, which shows you can overcome the mutation in these laboratory studies. And this was also true in a wonderful study led by my colleague Michael Wang at MD Anderson, where he took LOXO 305 or pirtobrutinib and treated a wide range of B-cell malignancies, including Waldenstrom patients. And he showed remarkable activity for patients who had even seen a covalent BTK inhibitor like ibrutinib, previously. And so this to me is very encouraging that we have here a very active drug that even when resistance does occur, that we can continue offering BTK inhibitor therapy to patients. And so my friend and colleague Jorge Castillo is now putting together this trial. We hope to have this open very soon. Eli Lilly has been very supportive of this trial effort. And this will be a trial where we'll be giving pirtobrutinib to patients who had previously seen one of these covalent BTK inhibitors like ibrutinib, zanubrutinib, or acalabrutinib, who may not have tolerated those therapies and needed to be switched over, or who progressed because of resistance. And so I'm excited by this trial because it will once again increase our armamentarium for treating patients with Waldenstrom's. In the last 2 slides, I just want to talk about a rational way of thinking about how to use the mutations to select treatment. This was published by us in the Journal of Clinical Oncology. This involves a schema where we know right up front what somebody's MYD88 and CXCR4 mutation status is. If they're MYD88 mutated alone, we tend to prioritize a BTK inhibitor because when you look at the activity of BTK inhibitors, even relative to other drugs like bendamustine and proteasome inhibitors, these tend to show a very, very good profile in terms of their activity, their safety. We do always have some worries around some of the other drugs that we use, like bendamustine, in terms of secondary malignancies, or proteasome inhibitors like Velcade or bortezomib, which can cause neuropathy. So when you think about balancing efficacy versus risk, here's why we prioritize a BTK inhibitor up front, even by itself, because we know that these work very well, so no need for adding in Rituxan. Now, if you have both mutations, on the other hand, what you got to think about is how fast you need a patient to respond. And many patients who have hyperviscosity, where their IgM is very, very high, need really attention. They need to get that IgM down. You'll usually do plasmapheresis to get the IgM down, but then you need definitive therapy to keep it down. And here we might prioritize a drug like bendamustine or a proteasome inhibitor, because these tend to work faster in this population of patients than a BTK inhibitor might. But if you're in no rush, and the patient has both mutations, here we might give the BTK inhibitor along with rituximab, because we did see that data from Innovate suggesting that we can get patients into a major response sooner. The real dilemma is the MYD88 wild-type patients. Currently, we use bendamustine or proteasome inhibitor-based therapy, but with the data now that we're seeing with Demopoulos in the study that was published with zanubrutinib, this might also be an option for treating patients with MYD88 wild-type disease, again, disease where there is no MYD88 mutation. Keep in mind, and this is important for you as patients to keep in mind, that we tend to hold Rituxan or rituximab for any patient that has an IgM above 4,000 because of the risk of a IgM flare. This is when the IgM can go up quite abruptly. So keep that in mind, have that discussion with your clinicians. Keep in mind that for patients who have a lot of disease outside of the bone marrow, we tend to advocate for bendamustine because it's very good at shrinking down nodes or big masses. We tend to use proteasome inhibitors, that's what PI means here, like bortezomib, for treating patients that might have the amyloid complication. And in these select patients, we might also think about using autologous transplantation. For patients with peripheral neuropathy because of IgM, we do like the idea of initially trying rituximab, but subsequently ibrutinib or bendamustine, depending on the severity and pace of progression. And in some patients, we'll also use maintenance Rituxan if they received Rituxan along with their drug up front. So you see here, there really are a lot of things that we do consider when we're making treatment decisions, which is why there has to be a lot of thought and conversation with your particular provider around these kinds of recommendations, because one shoe does not fit all. But I do think getting your mutation status up front and knowing about it will help. And the same is also true in patients who have previously seen therapy. The same kind of strategy we would consider, except now we also have the opportunity to consider venetoclax. This is not approved for Waldenstrom's, but it is approved for other diseases like CLL and mantle cell lymphoma. And I think it does, offer an opportunity as we think about additional therapies after somebody has seen a BTK inhibitor to be considered. There's also the opportunity for pirtobrutinib, although this has not been approved so far, and I'm hoping this will become part of our armamentarium in the future. At this point in time, I just want to summate by saying these are very exciting times for Waldenstrom's. We're actually using the genome to guide us in developing new therapies and employing them in our patients. And I think it is really important to have a very thoughtful discussion around the use of these newer drugs, particularly when one keeps in mind how the genomics are impacting outcomes. And with that, I would like to once again thank Dr. Beret and his colleagues for organizing this meeting and for giving me the opportunity to give you this update in Waldenstrom's macroglobulinemia. Thank you.